Hi, I'm Suneet Mittal for Heart Rhythm TV, and today at this Heart Rhythm Society meeting, I'm joined by Chris Cheung from Toronto, and we're here to talk about his PEACE AF study, which is being presented at this meeting. Welcome, Chris.
Thank you, Suneet, and thank you for the opportunity to speak on our study. I'm from the Sunnybrook Health Sciences Center at the University of Toronto, and we're very excited to present this study today at the High Impact Science session later today. PEACE AF stands for Prospective Evaluation for Asymptomatic Cerebral Embolism during or after an AFib ablation with pulse field ablation, so PEACE AF. And our study was looking for asymptomatic cerebral emboli after a PFA ablation. So in this study, we prospectively enrolled patients that were undergoing a PFA de novo AF ablation, and we performed a MRI of the brain within 72 hours after the AF ablation procedure. And then we also look at neurological outcomes. We have neurological questionnaires that we perform at baseline and at 3 months. And the big finding in our study is that we're reporting the rate of these asymptomatic cerebral embolism events. So to jump to the highlight of our study, we studied 35 prospective patients that underwent an AF ablation, and among these 35, 32 underwent an MRI, and we reported about 34% asymptomatic cerebral embolism rate. Now certainly we don't know the cause of these cerebral embolism, the etiology or the clinical significance, but it was certainly a very interesting finding to see a 34% embolism rate. We did some univariable predictors, which age was one predictor of embolism, and we did some preliminary multivariable analyses, although those are limited by power because of our small number of outcomes, and it appeared that age and persistent AFib may be associated with the outcome.
Yeah. So Chris, let me just ask you a couple of questions to unpack some of what you said. So first of all, this is a much higher incidence than previously reported. I know some of the prior PFA work has reported about a 10% rate. So I have a couple of questions. One is, why did you even feel the need to do this study when there was some background data? And why do you think we're picking up disparate levels compared to what we've been told historically to be the case?
That's a great question, Suneet, and that's certainly the impetus for why we did this study. We saw the prior work that had been done in these randomized and non-randomized studies that reported approximately 10%, but we thought that there was an important need to generate real-world evidence in terms of what is the rate when we do it in all our patients every day. So, not our real-world patients may not be the same as those that are enrolled in a rigorous randomized or non-randomized clinical trial, and so we sought to confirm that, and that's essentially the justification for this study. Why this event came about is perhaps one of the findings may be the fact that these are real-world patients that may not be as healthy or as robust as those that are typically included in a randomized trial. So there may be additional risk factors there that predispose them to developing these asymptomatic cerebral embolism events.
And can you remind us in this study, were things standardized with respect to, were you testing a particular PFA system, the anticoagulation status, ACT, was it pretty homogeneous how you managed sheets in this study? Some of the usual suspects that we think about.
Yes, yeah. That's a great question, Suneet. So this was it was standardized. So this was done with a single type of PFA catheter, the Pulse Select, and this all operators in this study typically held anticoagulation on the morning of procedure, but up until that, it was uninterrupted. Sheath management was the same. All our ablations were done with ICE catheter surveillance to make sure there's no left atrial appendage thrombus prior. Anticoagulation was given with heparin boluses given before the transeptal, and therapeutic ACT monitoring throughout the study, targeting an ACT of greater than 300 seconds throughout the left atrial wall. So we kept it as standardized as possible, and owing to always some minor differences between operators, but the main things such as anticoagulation, sheath management were all the same.
Yeah. Now, Chris, you've thought about this a lot, and obviously it's not possible for the average center to do MRIs on everybody, and so, having seen this finding, how do you think the field goes from here? Like, what would be your recommendation as we think about more and more systems being released on the market? How should we really get to the bottom line of this issue?
And that's a very important point, Suneet. I think there's multiple levels to that answer. I think first of all, as you mentioned, there are multiple systems that are coming onto the market. I think it's important for us that we develop studies that prospectively evaluate this. So in all the systems that come out, we should be systematically evaluating for this type of signal, first and foremost. Now, on top of that, I think we also need to better understand what's the cause and what's the subsequent impacts of these types of findings. So certainly at the in this study, we showed no clinical strokes that occurred, but these asymptomatic events still occurred. So we need to know, do these events have any long-term implications? So perhaps longer-term follow-up for these select group of patients would be the next step, at least to understand whether at 1 year or 2 years there's any significant neurological impacts of these findings. Those are my two takeaways.
Perfect. Well, Chris, I want to congratulate you and your authors for a wonderful study. It's been, we felt that it was innovative enough to highlight for further discussion. Look forward to the full, not only the presentation, but the data in manuscript form. And again, thank you for highlighting a very important area in the new world of PFA ablation. Thanks for joining me and giving me a few minutes.
Great, thank you very much, Suneet. And thank you for all our patients and families that participated in this study. It was a lot of work for them to come back for an MRI study as well, so we also wanted to thank you and recognize the patients and the families that participated in this study. Thank you.